Thank you, Dorit, and thanks to all the Hanita staff for being here in Milan in this magnificent venue. As you can see, my talk is a very recent one, but my experience here in this room dates back to when this room was still under construction. In 1980, I attended here my very first international meeting. I remember many doctors speaking English, and this room was so crowded and even hotter than it is this evening. My task today, and this is my financial disclosure, will be to talk with you a little bit about the BunnyLens toric. As you know, the world is going toric. Out of the abstracts we received as free papers here at the ESCRS this year, reporting and anticipating the presence of 7,000 doctors about, 400 dealt with toric lenses. So this is a hot topic, and every doctor seems to be wanting to implant toric lenses, and it's good news that we have reliable and new toric lenses like the one I will show you this evening. This lens is new, and I had my first experience here with this beautiful lens. You see the name comes from the haptics and the haptic shape. The total diameter is 11 millimeters, so this is a lens for the capsular bag. There is some haptic angulation. It's a 360-degree double square edge is there, preventing posterior capsular opacification. And I can tell you that my results with hydrophilic acrylic Hanita lenses are very, very good as for PCO. The material has an UV blocking and violet filtering chromophore, and the refractive index is 1.46. That means a high Abbe number. You may know that the Abbe number depicts the ability of any lens to reproduce colors correctly. It's a number that depends mainly on the refractive index of the material, but on the material as well. And as our spectacle lenses have some metal particles increasing the Abbe number, intraocular lenses haven't. And it's good news to hear that the Abbe number here is 55, and equally the highest Abbe number available in the market. Although the power range goes from 10 to 40 in 0.5 diopter increments, cylinders go from 1 to 10, but for my study, lenses were custom made by Hanita according to pre-operative evaluation we got. And this lens can be implanted through a 1.8 injector. This is not 1.8 incision, but incision is 2 or sub 2 millimeter. The material is a proven material, a well-known Hanita material, mixing HEMA and IOIMA, and it has a 4 pore centration to be stable in the eye, because, as you know, toric lenses must not rotate after surgery, but also during surgery, their shape should entitle us to easily rotate them. And the lens that can be rotated clockwise and counterclockwise is the best approach. Some complex software was employed to design those lenses. To minimize optical aberration, the lens is aspheric. To maximize MTF, MTF will depend on the aberration induced by the lens or the total aberration of the eye, and on the transparency of the lens itself. The Arizona eye model was used for designing this lens, and toric aberrations have been considered to improve the result in the presence of residual astigmatism. The design is not that simple, because as we implement a toricity on one surface, the principal plane of the lens will shift. And so the base power of the lens must be changed as well. So toric lenses have complex engineering. I will not go through them because I'm not in the position to do so. I'm a surgeon, and the surgeon can provide incision location and expected surgically induced astigmatism, while engineers are allowed to calculate the IOL power and the IOL mark axis. I filled up a form, and a few weeks later, not that many, I received the lens to be implanted and the spare lens. Manfred told you a lot about limiting PCO. For those of you who have no experience with Hanita lenses, I can only report my very favorable results with this lens. And it's very rare to YAG a patient, an eye, where a Hanita lens had been implanted. This study relates about 10 eyes of 6 patients, because you may know that many patients that have bilateral astigmatism, their corneal astigmatism varied between 1.2 and 6.9 diopters, being the 6.9 eye an eye with a penetrating keratoplasty done several years before and presenting with cataract. This was cataract surgery, no refractive lens exchange in these areas, and the IOL power range was between 16.5 and 26.5 diopters. The lens has marks sorry. It's the one in the middle. Perfect. Back in a minute. This one. Perfect. The lens has marks that help us in aligning it. However, for the purposes of this study, we didn't rely with complex machinery, because no toric lens would work if we need complex machinery to put it in place to align it. So I only had to mark the correct axis while the patient was sitting with a device including a pendulum. Then this was microincision cataract surgery, and lens implantation followed. This was a 24.5 lens with 2.5 diopter of astigmatism, and the injector was a Medicel 1.8. The lens was implanted with an incision-assisted implantation. A 24.5 entered the eye with no damage, and then it was only alignment. Alignment was rather easy because we can rotate the lens in 2 directions. As it's usually done with such lenses, we first align the lens with the viscoelastic in and then refine the alignment after viscoelastic removal. This is a comparison between the pre-operative corneal astigmatism and the post-operative refractive astigmatism. So in the pre-operative, the mean astigmatism was 3 diopter in the series. In the post-operative, it was less than 2. Results seem not to be so impressive, but the number of eyes was small and it included 2 eyes with penetrating keratoplasty. And these are the classes of pre-op and post-op astigmatism. In the pre-operative, astigmatism was varied a lot, and there was 1 eye with almost 7 diopters, and the other eye of that lady had almost 5 diopters. In the post-operative, the results were pretty good, and astigmatism was between 1 and 2 diopter in every eye, considering the total eye as compared with the corneal astigmatism reported for preoperative values. This is the spherical equivalent because the purpose of the study was also to gather information about the behavior of the lens in this respect. And the spherical equivalent was comprised between plus or minus 1.5 diopter, but emetropia was not always the target because a few patients asked for residual myopia to improve their near vision. What about axis location? Axis of the lens shift from the intended value. The mean shift in this first series of eyes was 7 plus and minus 5 degrees, but we had only 1 eye that was more than 10 degrees up to 15 degrees off the intended orientation. This is the uncorrected visual acuity. Results, are expressed in logmar, and the uncorrected acuity was very, very good, except the eye in which we targeted slow myopia. But the surprise was the subjective satisfaction of my patients. All the 6 patients were satisfied with the outcome, and none of them, this is quite amusing to me, none of them, even those who are a little bit myopic, even that lady with a corneal transplant who still has a 2 diopter astigmatism, almost 2, none of them is using a spectacle correction at the moment. 3 out of 6 do not use a spectacle correction at any time, neither for distance nor for near vision. I believe that micromonovision and the residual myopic astigmatism were the causes for this to occur in those patients. What we can conclude for this very, very first results and early study, that the Hanita BunnyLens, of course, TR is a mixed lens with toric optics. It can be implanted through a 1.8 millimeter incision up to 26.5 diopters. This was my experience, with no impairment of existing corneal astigmatism because it's mixed. It can be easily positioned by clockwise and counterclockwise rotation. In addition, it provided excellent visual acuity in this study, and independency of glasses was achieved despite small refractive errors for distant vision, and in 3 out of 6 of our patients also for near vision. However, for every toric intraocular lens, we can improve results by using complex devices requiring a lot of time and a lot of investment. But our BunnyLens TR provides good results without requiring perfection. I know Hanita is seeking for perfection, but please, as a surgeon, I'm pretty impressed and satisfied that this type of perfection is not required to me. And I thank you for your attention.